During our second annual BMO Obesity Summit in New York, Evan Seigerman, Managing Director and Senior Research Analyst at BMO Capital Markets, sat down with Katherine Saunders, MD, obesity physician and co-founder of FlyteHealth, to reflect on the transformation of obesity medicine throughout the past year. In this episode, Evan is also joined by Malcom Hoffman, Senior Equity Research Associate of BioPharma at BMO Capital Markets. Enjoy the episode.
Welcome to Markets Plus, where leading experts from across BMO discuss factors shaping the markets, economy, industry sectors, and much more. Visit bmocm.com/Markets Plus for more episodes. The views expressed here are those of the participants and not those of BMO Capital Markets, its affiliates, or subsidiaries.
Well, thanks everyone. It's my pleasure to be back at a bigger, better space for our second annual Obesity Summit. So with that, I want to welcome Katherine Saunders for what I'm calling Obesity 102, kind of catching us up on all that's happened from last year's summit to this year's summit in the treatment landscape for obesity and obesity medicines. I am joined by my associate, Malcom, who's going to help me moderate this session. Well, before we jump in, just a little bit of background on Katherine Saunders. We were actually introduced last year, and Katherine Saunders is a physician innovator and internationally recognized expert in obesity medicine. Aside from her appointment at Weill Cornell Medicine, she's the co-founder of FlyteHealth, which is an online platform that helps connect patients with providers in the medication and treatment that they need in the complex world of obesity medicine. She's joined by her husband, who's also the co-founder here today, and they've done wonderful things in making this critical life-saving medicine accessible to many, many more patients. So Katherine, thank you for joining us today.
Thanks for having me.
So Katherine, or Dr. Saunders, can you set the stage for how the medical community now views obesity, specifically kind of updates over the past year as the disease versus a lifestyle condition? I think we're moving away from the latter. And what has changed since we were sitting together on this proverbial stage last year?
Yeah, it's been an exciting year in obesity medicine. I'll start with the good news and then talk about a little bit of bad news. The good news is that there's so much more recognition of obesity as a real disease. Obesity as a complex, heterogeneous, chronic disease that warrants medical treatment. So if you take a look at the numbers, the increase in prescriptions for anti-obesity medications it's been about 50% each year since 2020. There's also much more interest among clinicians in getting into this field, which is great because we need so many more clinicians to be treating obesity effectively. In terms of physicians, the American Board of Obesity Medicine is the credentialing organization, and the number of physicians grew from about 4,000 in 2020 to almost 10,000 now. So humongous increase. And that's just physicians. There are also nurse practitioners, PAs, dietitians, so many other clinicians who are really excited about obesity medicine. The bad news is that we still have a lot of mismanagement and a lot of misunderstanding. So there is so much, weight bias, stigma, and discrimination that, we're addressing, but is really pervasive. And also just mismanagement. If you take a look at the numbers, the percentage of patients who continue on anti-obesity medications at 1 year is about 30 to 40%, which is not a good number considering that obesity is a chronic disease that needs to be treated long term. So we need so much more education of the public, so much more education of clinicians to really be managing obesity the way it should be managed.
Excellent.
Gotcha. And kind of going off that a little bit, you had talked about how the number of providers is really increasing, great for the space overall. The other thing that we've seen is kind of an advancement in terms of the therapeutics that are available. So now, kind of stepping back, we're about 4 years since the Wegovy approval at this point. A little bit more recently, Zepbound approval. Can you kind of talk through how that landscape has sort of evolved, starting with Wegovy, then Zepbound, and now maybe more recent agents, and kind of what that armamentarium is starting to look like at this point?
Yeah. So when Wegovy was approved in 2021, this was the first time that we had a single medication that was associated with greater than 10% total body weight loss. Previously, the medications we had were about 5 to 9%. So Wegovy was a huge breakthrough in our ability to really help patients in ways that we were never able to do before. The good news is that we now have medications like Wegovy at 15%, Zepbound at 22%, so many more in the pipeline that are associated with really significant weight loss. So for patients, it's amazing. I mean, it's just incredible how we're able to transform people's lives and help them lose more weight than they ever expected, and more importantly, achieve health outcomes that they never could have achieved before. The downside is that these medications are powerful and really need to be managed responsibly. We're seeing so much inappropriate prescribing. I mean, I saw a patient yesterday who came to me from another provider and had lost weight so rapidly that she has neurological complications. And this story is not unique. We're seeing this more and more. So we really need more clinicians who understand obesity at a higher level and treat obesity really responsibly. Just because we have powerful medications doesn't mean that every single patient needs the most powerful medication. I mean, in no other area of medicine do we jump right to the big guns right away. We start more conservatively and then we increase, in terms of our, risk profile and the power of the medications really responsibly. So on one hand, it is just so exciting. I mean, I can't even believe what we're able to help patients achieve, but this needs to be done really responsibly.
What does the ideal treatment look like? I think that's very important to emphasize that that can be one component, but how would you holistically treat a patient that is struggling with their weight? If they came to you, they not asking, not begging for one, what do you consider? What do you start with? And then how do you make that path to potentially a GLP-1?
Yeah, so don't get me wrong. I'm a huge proponent of GLP-1s. They've transformed our field and they're a really important tool for us. When a patient presents to us, it's really important for us to spend a good amount of time with them. So instead of having people fill out a form and get a medication sent to them, good medicine in this field really entails, one-on-one time with a patient. We spend an hour with each patient when we first meet them because it is so critical for us to understand for each patient every single factor that's contributing to weight gain and every single barrier that is preventing weight loss. So we collect all of this information by asking tons of questions, looking at a huge panel of labs. And then what we do is we use that information to then educate the patient on, this is a disease. It's not about willpower. In your specific case, there's a component of genetics, and that's how this works. There's also a component of whatever else is going on. And oftentimes it's, medications that can be leading to weight gain. Many of our patients are on medications, 1, 2, 3, maybe even 5 medications that actually cause weight gain. So that's a big thing we address. We also screen everybody for sleep apnea because that leads to weight gain, and many other comorbidities lead to weight gain, many lifestyle factors. So if we don't have that information and if we don't use that information in our comprehensive treatment plan, then we're not doing the best we can. So we do a lot of education so the patients understand, why we're making the recommendations that we're making and really, get that this is a chronic disease that needs to be treated very comprehensively and long term. In terms of picking medications, if there's a reason to go to a GLP-1 off the bat, maybe a patient has diabetes, sleep apnea, maybe their BMI is very high, we may do that. But otherwise, I always like to start with more conservative approaches because we have so much success doing that. And that's how we've always done it. And so if a patient even loses a portion of the weight they need to lose with one generic medication, and I can add a second one and then get them to 15% total body weight loss. Sometimes that's great, just given our landscape of, coverage, price, shortage issues.
And, as you think about kind of something you said earlier, only 30% of patients remain on therapy after 1 year. Those numbers are not great. What what are you doing, or what can the field do to improve those numbers? How do you have a motivated patient come in, they're all excited for treatment. How do you ensure that a year later they're still in the game?
Yeah. So I wouldn't start a patient on medication unless they were committed to some kind of medical intervention long term. Because looking at the data, when we stop medications, people regain weight. It's just like having hyperlipidemia or hypertension. You start a statin knowing that it's going to improve your numbers, but your numbers only are improved for the amount of time you're taking the medication, and we expect numbers to go up. So again, it's building trust with patients and, doing a lot of education. And again, if someone's like, I want to take this medication until I lose weight for something and then stop it, I would really, really caution against that, because then they're going to be in a worse position than if they had never taken the medication.
And kind of double clicking on one of the points that you mentioned at the start here, when you meet with your patients to begin with, you had mentioned that you go through this full 1 hour session where you're kind of evaluating them holistically, getting their full baseline, all their metabolic parameters and everything like that. But sort of beyond that, obesity is definitely a multifaceted disease where there's a lot of factors that kind of go into that, some of them being social, some environmental, some even policy, depending on coverage implications there. Can you kind of elaborate on that interplay with how each of these individual drivers, policy, community-based initiatives, individual behavior all kind of aggregate into obesity, and how you tackle them either individually or holistically together to kind of get the best optimal outcome for your patients?
Yeah. So on an individual level, again, it's just, getting all the information about each person's contributor and educating them and, helping them, meeting them where they are and helping them make, lifestyle changes, behavioral changes. On a bigger level, we need improved coverage. We need improved access to care. And there are so many barriers that need to be tackled. I mean, if Medicare would cover anti-obesity medications, that would be incredible. If more states, Medicaid would cover obesity medications, that would be incredible. If you take a look at other policies, stepping away from medications in terms of prevention, like, school lunches and soda taxes, there's so much of a focus on, changing lifestyle, changing diet, changing all of that. And when you look at the numbers, these have not been successful in terms of prevention, because that's not the whole problem. That's, a part of the whole picture. So we really need to kind of focus on what matters instead of what people think may matter but hasn't panned out.
And are you seeing momentum kind of building in all those areas, coverage, that sort of thing?
And what has changed over the past year in the field of, obesity medicine? I know you've been in the field for a long time, but it seems that from 2024 to now, a lot has accelerated. Maybe kind of give us an overview of, where the field has gone, what's going well, what's not going well, kind of a state of the state.
Yeah. So again, our ability to help patients in ways that we never could before is just mind blowing. And we have so many more medications in the pipeline that are even more powerful. So everyone is really, really, really excited about it. But I cannot stress enough that, with great power comes great responsibility, that everything needs to be done, thoughtfully in a very patient-centered way. One of the big things is just the extended indications. So Wegovy has an indication for patients who have obesity and established cardiovascular disease. It's approved to not only treat obesity, but also reduce the risk of cardiovascular disease. So that's been really, that was huge for the field. It was the first cardiovascular outcome trial, the SELECT trial, to show that in patients with obesity and not diabetes, because there have been other cardiovascular outcome trials in patients with diabetes. So this is obesity in and of itself, that a medication like this can be effective for cardiovascular risk reduction. So that really opened up people's minds to, oh my gosh, we're not just helping people lose weight, we're really improving health outcomes and reducing risk. So that was the first, expanded indication, which was very exciting. It always takes a little while for that to actually, happen in clinical practice where we can prescribe a medication for someone who has cardiovascular disease and have it go through. The second one is, Zepbound receiving the additional indication for sleep apnea. I mean, we don't have good treatments for sleep apnea. CPAP helps with symptoms, but doesn't help with, morbidity and mortality. And who can tolerate CPAP? So to have a medication that reduces the severity of obstructive sleep apnea, which is a huge problem, by 50%, I mean, that is mind-blowing.
Fixating more also on the specific patient again, we now have, multiple therapeutics that kind of patients can go after. How are you tying in those therapeutic treatments with specific interest in their diet, physical activity patterns? Obviously, all these things go together to tackle obesity, but is there some less focus from patients on those aspects of the treatment, and you kind of have to integrate them into that way of thinking of it's not just one thing, it's all this together to kind of get an optimal outcome? What's kind of the dynamic there?
Yeah, I think in terms of just a framework, obesity is a disease that is sort of characterized by dysregulated hormonal pathways that can be targeted by medication. So treating the disease of obesity medically, that is what leads to, outcomes in terms of weight loss and health outcomes. If you take a look at diet, exercise, and other behavioral interventions, those interventions don't lead to very significant weight loss. We focus on diet for health, but we don't focus on diet for weight loss. Same thing with exercise. Exercise is really important for health, really important for weight maintenance, but we don't say, just exercise more, eat better, and you're going to lose weight, because when you take a look at the data, and I'm happy to get into it, it doesn't work on its own for most people for clinically significant sustained weight loss. So we, treat obesity first medically, and then honestly, everything kind of falls into place for most people. Like once when you take a person who has obesity and they're hungry all the time because of their disease, they're thinking about food all the time because of their disease, when you treat the underlying pathways, it makes everything else so much easier. So when these medications started, coming out in ways that are just so much more powerful than we had before, everyone was like, we don't need diets anymore. We don't need dietitians. But that is not the case. It's really been a change in how dietitians practice. Our dietitians, are so good at helping people to tolerate the medications, optimize their diet, given that people are eating fewer calories. It's a different way of focusing. I think one of the things we're seeing is just sort of too much of a reliance on everything other than meds, and just really arbitrary treatments or arbitrary requirements. Like some insurance companies or some programs require that patients, log their food a certain number of times a month, or, and these numbers are really arbitrary. Like we don't have evidence showing that makes a difference, but we do have evidence showing that the medical treatment makes a difference.
Gotcha. And kind of talking about this point as well, you mentioned it, patients that, are maybe less successful with their treatment, even if they're on an incretin, what are some of the pushes and pulls that kind of lead to that? Is it, safety issues, is tolerability problems there, lack of efficacy? What are the main reasons that you're seeing patients really not get to the kind of goal that they want, both from a weight perspective and then also just an overall health? Like what are the drivers there?
Yeah, so it's really important to understand obesity as a very heterogeneous disease. So if you think about medications, there is so much variability in response to medications. And so if one medication isn't working because, the pathways aren't exactly the pathways that are dysregulated for that patient, then that medication is just not an effective medication for the person. It has nothing to do with anything they did wrong. It's just literally their biology. And that's why, we don't get discouraged when one medication doesn't work. We prepare our patients when we prescribe a med saying, we have a really good feeling about this medication. We hope this works. But if it doesn't, we have plans B, C, D, and E. So it really kind of comes down to biology and other factors.
Gotcha. And to your point around, obviously some patients fail because the specific mechanism that they're using for that drug is not ideal for their own individual biology. When you look at the therapeutic landscape for what's in the pipeline, what's available in the future, that must give you a lot of hope to some extent because there's a lot of variety. Just the change in diversity of targets that people are going after is really substantial. So how do you think about that as a physician and also like communicating that to your patients? Because it must be a little bit demoralizing to some extent if everyone you know who is obese is taking a GLP-1 and it's worked for them, and now suddenly your specific biology just doesn't match up with that, and it's not an ideal situation for you to lose weight.
Yeah, great question. It is so demoralizing for our patients. It's really frustrating. So, when we had semaglutide as the most effective medication, we had a subset of patients where we tried every medication, including semaglutide, and things just were not working. And then as soon as tirzepatide came out, we started them on tirzepatide. Right now, I have some tirzepatide non-responders. So when retatrutide comes out, I will be prescribing to them immediately. Day one, I can get my hands on retatrutide. So there are non-responders to each medication, but there are fewer non-responders as we target more pathways. So semaglutide is GLP-1, tirzepatide is GIP and GLP-1, retatrutide is 3 different pathways. So as we have more pathways that are targeted in terms of combo treatments or even just other treatments as 1 or 2, we'll be able to help more and more people, which is just so exciting.
I have to imagine that would also help with the cultural discussion as well too, because if patients start to respond with different mechanisms specifically, it's easier to point at it as this is a biological issue rather than something of willpower or something else like that. I feel like that makes that discussion a little bit more clear for everyone who's looking at it from this outside perspective.
Totally. I mean, when I started doing this, primary care doctors would call all the time being like, what are you giving my patient? What are you doing? And Dr. Roney, who'll be here this afternoon, who's my mentor, I literally, as a fellow, would go into his office and be like, this primary care doctor thinks I'm crazy. And he would be like, well, can that primary care doctor help their patients lose weight? No. So he would always say, prove them wrong. And we did. And so, we did that on a smaller scale a decade ago. Now we're doing it much larger scale. But you're right. It's, for people who think that this is just a lifestyle problem, showing that they're actually targets that, are dysregulated and, where there are things that are going wrong in people with obesity that are more than just lifestyle. Having medications that work for obesity really proves that it's more than just lifestyle.
And how do we solve some of the access issues? Is it, and this isn't just access to drugs, it's access to proper care. Is it educating primary care physicians so that they don't just think diet and exercise and, get out of my office? Or are there other things that the medical community can do to, help as many patients as possible?
Yeah, that's a question we think about all the time. So primary care doctors are totally overextended and generally don't have time to do what it takes to provide obesity care very well. I mean, we have a team of people who just do nothing but prior authorizations. Primary care, I'm serious, primary care practices just can't do that. And spending an hour with a patient just talking about obesity and then doing follow-ups that are, 20, 30 minutes, the primary care doctors can't handle all of this. So for primary care doctors who can and are interested, wonderful. They can get board certified. They can, develop an expertise in obesity. But right now, the best way to treat obesity is really in a specialized way. I mean, that's why we started our company. But it takes real expertise and it takes a real infrastructure of a whole care team and the support to do what's necessary at this point to support a patient and fight as hard as we can for coverage and access.
And how is kind of that whole care team improving, long-term compliance and persistence? How do you get that 30% number to 50, 60% so that a year and 2 years in, patients are, still on therapy or, most importantly, keeping the weight off that they've lost?
Yeah, great question. And not to brag, but our numbers are well over 80%. So
Yes.
we're very proud of our numbers. And it's because, we have incredible clinicians who are real experts and really care about patients. And our patients feel supported. And so different members of our team do different things. We have, physicians, nurse practitioners, dietitians supporting patients in different ways. We have other, support as well. But really educating and supporting patients is absolutely critical. And then the phase of weight maintenance is, a totally different phase than the phase of weight loss. So preparing patients for what it means once they've achieved their health outcomes to be in the phase of weight maintenance, or even having a weight maintenance program is something that is absolutely critical, so that patients understand, what they need to do in order to keep this weight off and stay on the medication.
And as I think about kind of what's next in the therapeutic landscape, and that's what we'll talk a lot about today, do you think that small molecule pills, longer acting, or kind of other modalities become more critical in that weight maintenance phase? Or is it really just continuing the work that you're doing now?
Right now, I would say continuing the work that we're doing now. I think there's so much interest in, helping people lose weight with one intervention and then changing to something else. We just don't have the data yet. And for the way we've been doing it, Dr. Roney's been doing this for over 30 years. The way to help people lose weight and keep it off is you titrate medication, adjust medication regimens over, it takes a lot of fine tuning in the phase of weight loss. And then in the phase of weight maintenance, we don't make a change. The medications stay the same unless, things change and we need to adjust because things are changing in weight maintenance. But the idea is not to completely change the treatment protocol.
We could have had a conversation for another hour, but thank you so much, Dr. Saunders. We appreciate you coming, and thanks for kicking us off.
Thanks for listening. You can follow this podcast on Apple Podcasts, Spotify, or your favorite podcast app. For more episodes, visit bmocm.com/marketsplus.
For BMO disclosures, please visit bmocm.com/podcast/disclaimer.